Hello, can you hear me?
Yes.
Oh, hello. Yeah,
Yes.
you're not with me, no? Right, okay. Uh, we'll start one of these papers here. Mm, we'll see whether you can rush through. Uh, Let us start. Hello? Hello,
Yeah.
can you hear me?
Yes.
There's a lot of thunder and rain.
Yes.
Got disconnected. Let's start again. These are true false series of true false MCQs. Um, okay. Which of the following are true regarding head injury? Blunt injury has bad prognosis. True false? Yes. Yeah. That is true. Generally, what happens is uh, penetrating injury is generally deadly if it just go through the brain substance. But blunt injury has two ways of destroying the brain parenchyma. That is causing intracranial hemorrhage and then direct parenchymal injury both. So out of these two, blunt injury has a kind of bad prognosis anyway. So because its mode of injury is multiple, it can lead to hematoma formation. Diffuse axonal injury also can take place due to rotational injuries uh, and deceleration and acceleration injuries, and also can lead to parenchymal hematomas. So that is true. And hypovolemia causes GCS reduction independent of neurological status.
True, sir.
Uh, yeah. Why did you say it causes GCS reduction independent of yeah?
Because hypovolemia itself can,
Yeah.
even though there's no any neurological thing, decrease brain perfusion and those things
Yes.
can
Yes.
cause.
Yes. Uh, yeah, that's true because it can lead to conscious levels, even if there is no direct brain injury. So hypovolemia independently can cause decreased cerebral perfusion and change in the conscious levels. But at the beginning, cerebral uh, autoregulation will try to maintain the cerebral perfusion. But if hypovolemia continues, it can affect the conscious levels. So it is true. So GCS less than 8 requires endotracheal intubation.
True, sir.
Yeah, that's true because that shows that the conscious levels are low and then it can affect the respiration any moment. So usually accepted GCS level is 8. If it is below 8 or below that, he is in impending respiratory arrest or respiratory failure. So you need to protect the airway by mechanical ventilation. So that is true. And pupillary dilatation is seen on the same side as the lesion.
True, sir.
Yes, at the beginning there will be a short constriction of the. I mean, if you have EDH, the pupillary dilatation is generally associated with the extradural hemorrhages. And then what happens is compression of the third nerve, know the mechanism, on the same side causes a very transient initial constriction of the pupil, and then it keeps on dilating. So later on, when the cerebral shifts take place, the other side also will get compressed, and then you get the contralateral pupillary dilatation. Just know that a little bit of details about it that this generally happens when there is subtentorium or below the tentorium, when there's a part called uncus brain, that uncus or uncle hemorrhage, uncle herniation is the one which causes third nerve palsy. So better to know the pathophysiology because MCQs can be modified to ask these things too. And that is true that dilatation starts with the same side and then go to the other side. Lucid interval is present in over 50% of extradural hemorrhages.
True, sir.
Actually, this lucid interval is a rare event, though we often talk about it. it occurs only in about 20% of people. Or some series, some studies, it shows even it is less than that. So generally what happens is the patient loses consciousness and then regains the consciousness. Initial loss is due to concussion, that is disruption of the synapses, and then he regains consciousness, and the hematoma will be growing inside, but CSF and the venous blood will get displaced, and the intracranial pressure will not go up. Herniation and intracranial pressure will not go up for a short period. That is the period which is called lucid interval. Then after that period, no more CSFO veins can, venous blood can get shifted. Then the brain start getting shifted. So on this called Monroe-Kelly principle. On this principle, the first sometimes few hours, the patient may be conscious again, and then when the brain herniation starts, he loses consciousness. But it doesn't happen in many patients. It's not a rule. So only about 20% of cases you find that. So 50% is definitely very high figure. So that is false. Okay. Right. Okay. I think, yeah, this answers are there. Let's see. Yeah. Okay. Right. Anyway, we'll discuss outcomes of the right-sided DVT could be. What do you think? The outcome of the right-sided calf DVT could be, could present probably. These are recall questions. So central abdominal pain, the answers are visible, isn't it? You can see the answers, can you?
Yes, sir.
Yeah, central abdominal pain, yeah, sometimes these are not hidden. So anyway, central abdominal pain is not a common feature of calf DVT because it can lead to a large DVT which is at the bifurcation of the inferior vena cava or inferior vena cava thrombus, can cause obstruction to uh, these bowel veins. Those are superior mesenteric and inferior mesenteric veins. Ultimately, because it causes some sort of but those are generally drained from the portal system. So usually the bowel won't get congested, but occasionally the zygous system can get blocked, and then you can get central abdominal pain when they have large clots, which is a rare event. So, because bowel is generally drained from through the portal system. So, this is a rare event where there are large IVC thrombi, but it's not a common thing. So, definitely calf DVT, you don't get central abdominal pain. So, that's why it is marked false. And hemoptysis is true because any calf DVT can lead to uh, can lead to pulmonary emboli, and initially the small emboli might block the pulmonary vessels and then cause hemoptysis. And when massive pulmonary embolus goes and gets stuck in the pulmonary artery only, you get what we call obstructive shock and the patient dies. So will lead to hemoptysis. So that is true. And pleuritic chest pain, again, which it is true because you can get obstructed pulmonary arterial segments close to the pleura. With this slight ischemic pain you can get, because pleura, as you know, is not sensitive to mechanical injuries. You don't get pain, but ischemia always causes visceral pain. So pleuritic type of chest pain is a known symptom of recurrent pulmonary emboli. And right calf pain is obvious answer because calf DVT, that is the weight presence with calf swelling and pain, and especially when you move the toe, big toe, and toe, you get severe pain. There was a sign called Homan sign. Uh, by flexing the ankle, you make the pain worse. But that Homan sign, remember, is no longer demonstrated or elicited because they have shown that during the Homan sign, the clots can get dislodged. So, if it mentions that Homan sign is a clinical uh, feature you have to elicit in calf pain, answer will be wrong because no longer people advise to do this Homan sign. And right ankle edema, generally what happens is the whole leg undergoes venous congestion. So you can get ankle edema and calf edema both. Uh, okay. Which of the following are true regarding the initial assessment and management of trauma? Chest X-ray, initial assessment of trauma, right? Chest X-ray AP is done to diagnose tension pneumothorax.
False, sir.
Yeah, yeah. Why is that?
We can clinically detect it.
Yes, actually, you don't wait for tension pneumothorax to get X-rays and things like that. You're right, because it is one of the life-threatening injuries in trauma. So others are cardiac tamponade and internal bleeding, rapid external or internal bleeding due to major arterial injuries, and intracranial hemorrhage, especially EDH. So those things are rapidly sort of life-threatening injuries, and you don't wait for investigations. Clinical diagnosis, unless you are in doubt, you start resuscitating the patient according to the ABCD protocol, ATLS protocol. So, if it is tension pneumothorax, needle thoracentesis or needle thoracostomy has to be done immediately, followed by a chest tube insertion. So you don't waste time for chest X-ray. So that is false. FAST scan can detect fluid in pericardium.
False.
Yeah, actually speaking, this is a badly recalled or badly set MCQ, because fast scan, there is the simple fast scan and there's a thing called extended fast scan. Extended fast scan can detect lung fluid and the pericardial fluid as well. So if it is done by an experienced person, extended fast, so this doesn't specify. So pericardial fluid, when you hold the scanner close to the subcostal margin, actually you can detect pericardial diffusions and cardiac tamponade. So fast scan, I think, in these days, done by a specialist in trauma surgery, generally the people who are on call there, this has to be taken as true, because fast scan can be, though it says that it is only for the abdomen, because the FAST stand for focus assessment with sonography in trauma. So that doesn't say that only the abdominal fluid there it's going to detect. So I would mark it as true. Extended fast scan. Remember the word extended fast scan can detect pleural and pericardial fluid as well. Needle thoracentesis is done to decompress massive hemothorax.
False, sir.
Yeah, that's definitely false because
Sir, excuse me,
yeah,
sir. We did this question before in a previous session, sir.
did we? So then,
Yes, sir.
if this, you mean this whole series? Let's
Uh,
see. Let's move. If you remember it, we'll just skip them. Okay. It's a whole series because some of these questions are given here and there. Let's see. Now, can you remember the other one also? This next one, chronic pancreatitis. Because some of the MCQs are mixed up. These all Zoom sessions we have done. So can you remember these? If you remember, just let me know if you have done it. I know a lot of people have joined, I think now. Right, okay. So
So we did this also, sir.
we did also, no? So I think probably we will skip this. Give me a minute. I will. Now, where did we stop doing this previous series? Let me change this into another series. There are a whole number of sets of MCQs. Give me a minute. I'll just close this because no point doing it again and again. No. No. Hello, you are with me or?
Yes, sir.
Yeah. Now have we done this this one? I don't know whether we have done with you all. Yeah, I do with some other groups also. Let's see. I'll put one or two. See whether we have done these things regarding Barrett-Cephalopolysis and things like that. Have we done? Because I'm not quite sure where we stopped because some of the questions we missed regarding connective retention, high phosphate volume. Single best answers. Can you see the screen now?
I can't see the strings.
I can't see the screen, no? Let me, yeah. Let me put this series, see whether we have done it, okay? If so, we'll run fast. This is another series. Have we done this part? This Barrett-Cephalopolysis and things?
Yes, sir, we did.
This, yeah. So this series also we have done, no? We are presented with acute severe bleeding per rectum.
Yes, sir, we did.
We did this, no?
Yes.
And don't know where it was. There are 200 in this series. I don't know whether we single best answer this one. Let's see. Check. Have we done that one? Because
Yes, sir, we did.
this also we have done, no?
Yes, sir.
Somewhere we probably stopped. What disease I can remember? This one?
No, sir, we didn't do.
We have not, no?
No,
So
sir.
we don't know where we stopped with you all, actually. Potts disease and these
Yes, sir, we
osteoarthritis.
did. We did
So I
that, sir.
think probably it's here we stopped, no? So
Yes.
let me, yeah, okay. So you can see the full screen now?
Yes, sir, we can.
All right then. Um, okay, right. Now let's start from here. We'll go fast. No, the series has 200 pages. Okay. 25-year-old female presented with high fever and right-sided loin pain for 3 days duration. Pulse rate high and blood pressure 80 by 40. WBC also high and CRP very high. And NCCT revealed right-sided mild hydroureter hydronephrosis, 1 centimeter calculus at the right pelvic junction. Antibiotics and IV fluids are given. What is the most appropriate next intervention after the initial stabilization? Can anybody try this? Or
Caesar is obstructed infective
Percate.
system.
yeah, yes, obviously. Now this is a situation where you have urosepsis secondary to an obstructed kidney, and then it's kind of a septic shock. If you look at all these parameters, creatinine is also high because she's heading for AKI. And first thing we have to do is, in this situation is to relieve the kidney. So now, suppose there is an answer here saying that double J stenting. It's not put here. Shockwave, obviously wrong, because during infection, we don't do any intervention. Because if you crush the stone or do anything to definitive treatment, you will end up in septic shock. So medical dissolution, again, out on the same grounds. Pyelothotomy is a major surgery. We don't do that. Right ureteroscopy and laser lithotripsy is again a procedure. So in septic shock, we don't do procedures. Whole idea is to decompress the kidney. But what is better if this person who has made this question, if they have put double J stenting, what do you think is more appropriate?
Still Caesar.
Yeah, still C. Because double J stenting doesn't drain. J stent doesn't drain pus or infected urine with particles as effectively as PCN. So PCN again done under local anesthesia. So because of that, the septic patient has to be put under general anesthesia if you are going to put a J stent, because we are going to do a cystoscopy. So on those grounds, if there is a septic and obstructed kidney, best thing is percutaneous nephrostomy done under local anesthesia by the interventional radiologist.
Excuse me, sir.
Yeah.
JJ stent can't be put it under local. Spinal anesthesia.
Even spinal anesthesia, there is a high chance of that if the bone is obstructing, there's a possibility of failing. So the septic patient is an ill patient. So even spinal anesthesia carries the same risk, because as you know, spinal anesthesia can give rise to vasodilatation and then again further pressure drop. And also in the presence of sepsis, spinal anesthesia is something the anesthetist will not be very happy to do. So it is not the anesthesia, it is the difficulty of putting the stent. So there is a good possibility that 1 centimeter stone, if it is badly stuck, then the stent will not go. So that you have to do the last one, E, ureteroscopy and laser lithotripsy, which can lead to further deterioration of the situation by leading to septicemia and shock. Because you have to send a lot of saline to crush the stone, and then that increases the intra-pelvic pressure inside the renal pelvis. That will precipitate a further or worsen further septicemia and septic shock. So, in a infected and especially in septic urosepsis, best way of decompressing is PCM. So, if J stent is there even, still the answer will be C. It's not the anesthesia, it is the anesthesia also part of it, but it's just because it can be done under spinal, that is not the best.
Thank you, sir.
Okay. 50-year-old female presents with acute pain over the left submandibular region. Yeah, if you remember doing this, then we'll skip this. So many. Left submandibular region, which increases following meals, mass palpable, and it was tender. The ultrasound shows stone in the proximal part of the submandibular duct, and inflammatory markers were high. So, most appropriate next step. So, after reading this stem, you know that the situation is submandibular silidinitis. Silidinitis, isn't it?
Yes.
Yes. The now this says that the stone actually the stone is generally palpable in the floor of the mouth, and then it is blocking the gland, and then it's causing infection. So basically what we have to do is to relieve the obstruction, and antibiotics is a must. What you said, that so whatever the answer which has the antibiotic has to be true. So there is only two answers. These of you argue these things. There are two answers with antibiotic, two or three answers. No? Yeah, antibiotics and xylogram, antibiotics and submandibular gland removal, that is salidinectomy, and extraction of the stone under direct vision. Out of these three, there is no point doing a xylogram because already palpable mass is there, that is the infected gland, and ultrasound has already shown that there is a stone in the proximal part, which is close to the base of the mouth, and then oral cavity. And then, doing silidinectomy and injecting the dye itself can cause, as we know, infected system generally, on principle, injecting contrast is not the best thing to do. It can lead to further infection. So, doing a xylogram is not the best thing to do, appropriate thing to do. And then elective silidinectomy, this is an urgent situation where there is infection going on. So elective silidinectomy is also right, but that is for recurrent infection, and even after removing the stones, if there are recurrent stone formation or submandibular gland duct ends up in a stricture, then of course you have to do a silidinectomy, but that is an elective procedure. So it leaves its antibiotics and extraction of the stone under direct vision as the correct answer. Some of these stones, most of these stones are palpable or sometimes visible under the tongue. So true is yes. 6-year-old woman presented with recent onset back pain. X-ray spine shows fractures, including first and second lumbar vertebra. Serum investigations are as follows. Calcium is low. Phosphate is also low. Creatinine is normal. Most probable reason for this presentation. What do you think is the answer? There's low calcium. and low phosphate also, and normal creatinine. Most probable reason for the above presentation.
B, sir.
Why?
The low calcium and low phosphate with normal creatinine. So it can't
Yes.
now if
To
it's
exclude one by one. Why not metastatic cancer? The first one.
it's also lytic lesions or sclerotic lesions.
Yes. So why? How can you exclude that? She has got a back pain, and then there's a fracture now. So metastatic cancer can lead to that situation. So how would you exclude that?
Recent onset back.
Yeah, that's how they present. They get they have the primary cancer, and you get recent onset backache. And yeah, it's the importance of going through these MCQs carefully, because you will never get this MCQ again. Very unlikely. They will modify these things. So you have to know how to exclude these.
Their
One by
calcium
one.
levels are normal, sir.
Yeah,
Metastasis, their calcium levels are normal.
they are normal or more than that. If it is multiple metastases, calcium levels are high. It's well known that if you have a lot of lytic lesions, it's like breast cancer, then what happens is the bone get dissolved, and then you get hypercalcemia associated with other features of primary cancer. So this low calcium level actually, to a great extent, it is either normal or it is high in metastatic cancer. So low calcium puts this as not the best answer. Okay, that's the reason. And all the other things can happen, like recent onset back pain, lumbar vertebra compression fractures. So, right, osteoporosis. Why is it? Why osteoporosis is not wrong? Why it's wrong, or it's not the best answer? Because sometimes when you all have done this question earlier, the correct answer is in your mind. But the whole idea is to why you have excluded the others. Then only you gain knowledge. So why did you say that osteoporosis is not the best answer? Yeah, so that can lead to this type of backache, and then can show fractures, compression fractures, because of the weak bones. So yeah,
Phosphate levels. Phosphate levels.
yeah, phosphate levels are low. Yes. So is that the reason why osteoporosis is not right? Osteoporosis, what you have to remember is, it is the bone density which goes down, and it has nothing much to do with serum calcium or serum phosphate. So because of that, generally in these cases, you do a DEXA scan or something like that, you find that bone density, mineralization is low, but in most cases, it doesn't cause low calcium or low phosphate. So in most cases, it is normal, these two. So because of that, osteoporosis is unlikely. Primary hypoparathyroidism, how did you exclude that?
High calcium.
Yeah, hypoparathyroidism will cause
Yes.
high calcium, because it is due to either hypertrophy or parathyroid adenoma or parathyroid hypertrophy, and hyperplasia. So that will lead to high calcium levels. So that is one of the main features of primary hyperparathyroidism. So it is this calcium is low, so that can be easily excluded. Then tertiary hyperparathyroidism. Sorry, not tertiary. Secondary hyperparathyroidism. How did you exclude secondary hyperparathyroidism?
Normal
Usually
serum
there's
creatinine.
a renal pathology, so there's no
Secondary,
renal
how
pathology.
do you get secondary hyperparathyroidism?
Due to hypocalcemia, due to
Yeah, hypocalcemia due to some other reason, like either vitamin D deficiency or some sort of say intestinal malabsorption. So what happens is, calcium levels go down due to due to some other reason, and the parathyroid tries to compensate it. Okay, so what happens is it increases the parathyroid hormone release, and then actually sometimes it compensates it. Sometimes before compensation, if you do these tests, you find that calcium levels are low, because that is the thing which has triggered this situation. So secondary hyperparathyroidism, we can't exclude 100%, because that secondary hyperparathyroidism, calcium levels are low, so that triggers the secretion of parathormone. But initially, parathormone try to balance it, but sometimes the parathormone levels are high, but calcium is not corrected yet. So you can't exclude it completely. Tertiary hyperparathyroidism.
It has very high calcium levels and very low phosphate levels.
Yeah, true. But
Calcium level should be high, sir, in tertiary.
yeah. When do you get tertiary hyperparathyroidism?
In renal impairment,
Yeah, in chronic kidney disease is the common thing where you get tertiary hyperparathyroidism, where this production of active vitamin D is not there. So what happens is that can be excluded. That's why there's the reason this question has given creatinine, normal creatinine. So because of that, again, PTH levels are very high because parathyroid is trying to compensate it. But calcium levels are either normal or little low, but it is associated with kidney disease. So generally, this is what happens. 125 alpha cholecalciferol production is affected. So why this question they have given normal creatinine is to exclude tertiary hyperparathyroidism. So that leaves us with the secondary hyperparathyroidism as the answer. Tertiary is excluded, primary is excluded, osteoporosis, both are normal, so that is excluded. Metastatic cancer, again, will cause hypercalcemia. So
in secondary hyperparathyroidism, isn't phosphate like in the normal levels?
it can be initially, I think it can be both low. There's no rule to say that, these phosphates are low. What happens is that calcium is low. Sometimes when the absorption of phosphate is also low, you can have low phosphate levels. So I think by exclusion, this seems to be the most appropriate answer. Because other things, there are strong strong factor against them. Okay, so yeah, answer is D. But remember, actually, this is also, I think, this is probably badly set MCQ. But important thing is that generally, if the calcium levels are low, that will not exclude secondary hyperthyroidism. In initial stage, this low calcium is the stimulus for the secondary hyperthyroidism. 40-year-old man presented to the emergency department after 3 hours of being trapped in a house fire. On examination, he had facial burns and hoarse voice, and he also had bouts of cough and noisy difficulty in breathing. He is on 100% oxygen via face mask. What is the most appropriate next step of management? Yeah. Any idea?
Emergency tracheostomy, sir,
Tracheostomy, sir.
due to HCA formation.
Okay. Tracheostomy. So tracheostomy, you must take it as a serious undertaking. And this patient is now, there is a lot of facial burns, and he is coughing and he has noisy difficulty breathing. That means there is laryngeal edema, and also he is going towards respiratory failure. So because of that, in emergency situation, you do tracheostomy, only if the endotracheal intubation fails. Must remember that. Suppose he has a severe glottic edema or facial burns, or in some instances, say it's a facial fractures or facial-maxillary fractures, where endotracheal tube or nasotracheal tube cannot be put, then of course we go for straight away emergency tracheostomy. But next step, when it says next step, it has to be, if you are going to maintain or give a definitive airway, it has to be endotracheal intubation.
So in
So-
inhalational injuries, do we intubate?
Sorry?
Like in inhalational, like this situation,
Yeah, first important thing is that first attempt is to, now suppose if he's in a ward or in the ward or theater, first thing is to put an endotracheal intubation, because that is the easiest thing. Failing that only, you go for endotracheal, emergency tracheostomy. So always remember that easy way out is endotracheal intubation. So that I was telling you, the severe facial edema or failing, the anesthetist or experienced person fails to put an endotracheal or a nasotracheal tube. Both have to be tried, and both are failing. Then, of course, you go for emergency tracheostomy. So the answer will be going between these two. Oropharyngeal airway is going to be obviously wrong, because oropharyngeal or Goodell tube will only relieve the obstruction at the oropharynx level. So below that, that is the glottis and the tracheal level, that will not get rid of the block. So it is obviously wrong. Propping up the patient is not going to help, because very soon his oxygenation will go down. And so ultrasound scan, maybe part is missing there in that answer, but that has nothing to do with this situation. So your answer will be between the emergency tracheostomy or endotracheal intubation, but always you start by attempting endotracheal intubation. Only thing is, we have to remember is endotracheal tube can be kept only for about a week or maximum 2. And if it has to be kept for longer than that, you have to convert it into a elective tracheostomy. You know why? Why do you have to convert it? Why can't you keep an endotracheal tube more than a week or 2? Maximum?
Hospital-acquired pneumonia,
No,
ventilation.
no, not really. Both carries the chance of infecting. Why can't you keep an endotracheal tube for more than a week?
Tracheomalacia.
Malaysia,
Not actually.
the
Tracheomalacia
blood
is
vessels become causing ischemia due to the cuff.
ischemia to
The cartilaginous.
cuff. You mean the cuff? But both have cuffs, no? Endotracheal tube also has a cuff, and tracheostomy also has a cuff. So both have that problem. It's very simple. We try to remember it. Endotracheal tube goes through the vocal cords, glottis or vocal cords, and that will lead to irritation of vocal cords and continuous edema, plus vocal cord injury, inflammation and injury. Okay, so that is the very reason why you can't keep it for too long, endotracheal tubes, because it goes through the vocal cords. Tracheostomy is not. It is going below that through the trachea, so that injuring the vocal cords will not happen. That's the reason, right? The answer will be C. 40-year-old man presented with, we have done that. Okay, let's go for another one. A 60-year-old male patient presents to clinic with non-traumatic ulcer, measuring 2 centimeters in size in the maxillary area for 8 weeks duration. Yeah. And what's the most appropriate next step in management? Yeah. What do you think this is? Actually, these should specify. I don't know whether, because maxillary area is not good enough. they must say it's intraoral or in the surface of the maxilla. So that part is missing because ulcer can be there intraorally or it could be the skin ulcer. So maybe that part is missing there and it's an ambiguous question. But anyway, 2 centimeter ulcer, let us say it is the surface or the skin, and for 8 weeks it has been there. Non-traumatic and non-traumatic ulcer. So what is the possibility?
Leishmaniasis.
Sorry? Non-traumatic ulcer, generally you have to, 60-year-old man, persisting over more than 4 to 6 weeks without healing, you have to think of actually the skin, you have to think of basal cell carcinoma or a squamous cell carcinoma, one of those skin cancers. If it is inside, if there are no ragged teeth or poor oral hygiene, and then if it's not an abscess ulcer, if it lasts for more than 4 to 6 weeks, you have to take it as a oral cancer. Okay. So if it is a traumatic, if you have some ragged teeth and it has appeared less than 4 weeks, it's painful, then of course it can be a traumatic ulcer. But if it is a atraumatic ulcer, always consider that as a oral cancer. So keeping that in mind, apply antibacterial cream.
Also,
False.
Yeah, it's false because without knowing the reason and cause and without giving any clues about signs of infection, then it's false, obviously. Complete excision.
Because
All,
it's a face, we don't do that.
yes, I think you have to know the exact pathology to find out what sort of a clear margin you are going to keep. So if it's a very small ulcer, say 1 centimeter or less, a small one, you can make a cosmetic incision according to the Langer's lines and then excise the whole lesion. But 2 centimeter is too large for that excision without having a pathological diagnosis. So complete excision is not the best thing to do as the next step for 2 centimeter, that is a big ulcer, large ulcer. Cryotherapy.
False.
Yeah, you don't treat ulcers without knowing the histological diagnosis, so that is obviously false. And incisional biopsy?
True, sir.
Yeah, it seems to be the answer because all ulcers, incisional biopsy is the initial step. And reassure and review also out because it suggests a malignant ulcer. Even if it is inside the mouth, more or less these principles apply. You don't go and do excision and things like that. But first thing is you do a incisional biopsy, which should include part of the ulcer plus part of the normal tissue at the edge. You take a wedge-like piece. You don't just do punch biopsy. So just take only the ulcerous part. So what you have to do is you have to go to the edge, and from the edge you take a wedge shape incisional biopsy, which should include the ulcer plus the normal tissue. So just know the principle of doing incisional biopsy. 2 will be D. 50-year-old man who underwent mesh repair for inguinal hernia 5 days ago presented with fever, tenderness over the surgical site. He also has diabetes mellitus and hypertension for 5 years. Pus from surgical site has been sent for culture. So oozing with pus 5 days. So what will be the best treatment? Any guesses or any answers?
D,
Yes.
sir.
Suture removal and IV antibiotics. Okay, that's possible.
A, sir.
IV
IV.
antibiotics alone. Now, when you get pus from any part, it's very important to find out whether there is deep-seated abscess and you have to treat that, the cause of the abscess. Because IV antibiotics alone will not be the most appropriate. IV antibiotics will be only for superficial infection. All surgeries have two types of infection. One is superficial surgical site infection, SSI, and then DSI, that is deep surgical site infection. Deep surgical site infection means the deep tissues have got infected and pus has formed. That's why pus coming out. Superficial infection is that stitch abscesses and only the wound edges are red and erythematous, but there is no underlying abscess formation or pus discharge. You must remember these two categories very clearly, because treatment is different. So IV antibiotics, or in that case even oral antibiotics, is only for superficial infection. And this is definitely not superficial infection because pus is coming out. So that is the key word here. Okay. Diabetes, then also a diabetic, and pus has come out. So that is not the correct answer, but IV antibiotics is a must. So IV antibiotics and mesh removal is the second one. So that is up in the cards. So we'll go through the others. Now this type of question, when you find the correct answer, you just mark it and go through the others also. Because there is many occasions you will find that the better answer is there, which comes later on. So this is probable. So we have to keep that in mind. Oral antibiotics and early review at the clinic is out because of the pus, eluding pus there. And then suture removal and IV antibiotics. Also, it is actually that is up in the cards. So that's why I was telling this IV antibiotics and mesh removal or IV antibiotics and suture removal. Those are the two most appropriate answers here. So you have to decide one. If it's a true-false answer, both are true. Remove sutures and oral antibiotics. Oral antibiotics is out when there is infection with a foreign body underneath. So this catchy thing is that when there is a foreign body underneath, that has got infected and there is pus coming out, what happens is mesh has to be removed. So that is, it looks very shocking and it's unrealistic, but that is the principle. Principle is once a foreign body has got infected and there is pus formation, if you leave the mesh or the foreign body, it will continuously get infected and also it will lead to sinus formation. It will lead to chronic sinuses. So retaining that infecting mesh is not the best thing to do. So definitive treatment is you remove the mesh and drain the abscess, treat him with IV antibiotics, and at a later date, you can repeat the procedure once the infection is completely settled. So if this doesn't say about pus, if it just says that there are stitch abscesses or just erythema, then of course IV antibiotic can suture removal also may be right. If it is a superficial infection, because if there is tension there on the sutures, you can remove part of the suture. But when the mesh is there and pus is coming out, most appropriate thing to do is to remove the mesh. Okay. 65-year-old smoker presented with hard, non-tender lump in the carotid triangle of his neck. Chest X-ray was normal. Ultrasound of the neck revealed lymph node. FNAC revealed a squamous cell carcinoma. Most appropriate investigation. Yeah?
D, sir.
Yes. Why the others are wrong? Why is A wrong?
It is most likely a metastasis. So smoking
Yes.
might be a oropharyngeal or a.
Yeah, that's true. That is true. But why is CA levels wrong?
Non-specific.
Not really. CA is done for what? What sort of carcinomas? It's done for colorectal and adenocarcinoma.
Adenocarcinoma.
So this clearly says squamous carcinoma. That is the knowledge you have to have. Huh? So the CA levels are done for adenocarcinomas and colorectal cancer. So it is not relevant for squamous carcinoma. So that is why it is wrong. And excision of lymph nodes, why is that wrong?
The primary pathology, we should find the primary pathology first.
Yeah. But you have to get some idea about the lymph node before you hunt for the primary pathology. But that is there now. Already it is given that FNAC has been done and it says squamous cell carcinoma. So once that is there, there's no point trying to remove the whole lymph node and try to prove it again. But if this part was not there, answer should be to start with the FNAC. If the FNAC was not included in the stem, first step is to do FNAC and get what kind of a malignancy or the pathology going there. But excision will be an extreme thing where FNAC is or co-biopsies are not giving the answer. So that is out because already diagnosis is there. CCT chest is wrong is why? Why is it wrong?
Is to like stage the disease after the primary pathology is...
Yes, once it is found, yes, it is done. Usually, it's done as a staging disease, but then it at some stage for diagnostic purposes also you can do because lung apical tumors, squamous carcinoma, apical tumors can come as neck lymph nodes. So, but it is not the most appropriate next investigation. But as you said, when you have a neck mass and it is a malignancy, 80% of time it is a primary malignancy is in the upper aerodigestive tract. So what you have to do is you have to investigate that with endoscopy. That includes rhinoscopy, laryngoscopy, and upper GI endoscopy. Those are the three things you have to do. That is what means by saying aerodigestive. So endoscopy of aerodigestive tract has three parts. So remember, you have to investigate those three to find the primary. So that's the correct answer. Co-biopsy of the lymph node is wrong because if FNAC is positive, absolutely no point going for a co-biopsy. So unlike breast cancer, you don't do hormone levels, so you don't need any pathology from the definitive pathology from the lymph node. So co-biopsy is done to get histological diagnosis, which is not necessary in this type of a situation. 2D. Young male motorcyclist sustains head injury after a head-on collision. RTA, GCS is 8. Intubated and ventilated. CT brain shows intracranial hematoma. And what is the most important step to prevent secondary brain injury while awaiting evacuation of intracranial hemorrhage? What do you think the closest and correct answer? And why are the others not so correct? Any guesses? Any attempts? Yeah. Well,
So D, sir?
yeah, exclude one by one. Yeah. Tell me why the others are wrong. Dexamethasone administration.
Dex and mannitol can be given to reduce cerebral edema.
Yes. So why is it wrong? Why is it not the
It
best
is more
thing to do?
likely we are doing later, like if
Yeah.
we are not doing it immediately, sir.
Most important step to prevent secondary. It is not giving any timing. Will it prevent secondary brain injury? Okay. So it doesn't say immediately or late or whatever it is. So if it is given, that is right. So why is it wrong? Dexamethasone administration in trauma, it has been shown that it's called CRASH 1 trial. Steroids in brain edema secondary to injury. It has been shown that there is no advantage. CRASH 2 trial is different. That is for hemorrhage. CRASH 1, though the names are same, remember that. So generally we give. Now, this is effective if there is brain edema secondary to brain tumors or some sort of a chronic space-occupying lesions, but not for acute brain injury. So that evidence is the one which goes against giving dexamethasone administration. So in traumatic brain injury, steroids have no place. At any moment, we don't consider now steroids. Spinal cord injury, methylprednisolone is given to deal with the spinal cord edema and ascending paralysis, but not the brain injuries. So know that fact. And mannitol is it goes for same for same reason. Use of mannitol is also now given up because it causes it just it reduces the edema to a certain extent, but intermittently. So because of that, and then it can be positively harmful because, as you know, mannitol is a diuretic, osmotic diuretic, and it can lead to hypovolemia and hypotension. That can worsen the brain injury. The secondary brain injury means that primary brain injury is what you get then and there. Secondary brain injury is secondary to hypoxia and hypotension. So must remember the reason. So mannitol can actually, they have shown that it can make it worse. So because of that, mannitol infusion is also now no longer recommended as a treatment. So dexamethasone and mannitol is out. Elevation of head. Can that improve the cerebral circulation?
Yes, sir. Venous drainage
Yeah.
improves.
Yeah, actually, it has been shown that 30 degree of elevation can improve it and prevent secondary brain injury. But so that is a possibility, but you have to go for the best answer. So this type of question, you mark that, leave it, but don't mark it as the correct answer. Then go for maintain PCO2 less than 35. Why is it wrong?
So usually we do controlled hyperventilation to do
Yes.
vasoconstriction in brain. So this answer is true, sir.
Do you think that it is? Why is it not true? Hyperventilation, you are trying to leave it at a level of 30 to 35, true, and it can lead to cerebral vasoconstriction, hyperventilation, and actually in some instances it can worsen the ischemia. So emergency situations with impending herniation, we do this hyperventilation and keep the thing out. But this patient has not gone to that level actually. This question is, what is the most important? So as a desperate measure, this hyperventilation and trying to keep this PCO2 low is a measure you do. That's why these best of 5 answers all are right. Elevation of head end is also right. PCO2 less than 35 is also right. Mean arterial pressure 65 is also right. So out of that, you have to select what is the best. So what do you think the best?
We should maintain adequate cerebral perfusion
That is the
pressure.
most important thing in overall, in general, to maintain the mid arterial pressure over 65 is the key to prevention of secondary brain injury. To prevent, to maintain the cerebral perfusion. So all the other things are also right. They are done, elevation of head end, and in desperate cases at the far end, we do this hyperventilation and carbon dioxide lowering. But most important thing is throughout the, while he is waiting for the surgery, you have to maintain the blood pressure, especially the mean arterial pressure. So that's why that's the best answer. These are tricky questions. These are all best of 5 answers are like that. You can do everything, but you have to select the best. So the answer will be D. Yes. but know why the others are wrong. Because sometimes this may be converted into a true-false answer. If it is true or false answer, all these three are true. Except this A and E, others are true. Okay, that's why you have to know the reason. Because when you pull out these things, questions from the question bank, examiners, all these questions are now being asked, so you can't make new MCQs. What you have to do is you can modify. One way of modifying is that you convert a best of 5 answer into true or false. So if you don't know, you would have seen this question in the past, but if you don't know why exactly you exclude the others, you will get stuck in that situation. 23-year-old man presented with right-sided chest pain. He is a non-smoker and has no known lung disease. On examination, there is hyperresonance and reduced air entry on the right side. X-ray revealed 1.5 centimeter air column in the pleural space. What is the most appropriate management? Yeah,
Yes, sir.
you think A, yes. So administer high flow oxygen. Now it says, now read this carefully. He's a healthy man, young fellow.
B,
Okay.
sir.
Yeah. Okay, admit and observe. That is also right. So high flow oxygen, is it going to help?
There is no signs of respiratory distress.
Yes, yes, yes. The problem is that high flow oxygen will not help much because, as you said, if there is not mentioned, they have not mentioned about respiratory distress or some sort of a tachypnea or low arterial oxygen pressures. Nothing mentioned. Straight away, administrating high flow oxygen might not help. It can be done, but it may not be the best answer. Admit and observe.
Yes, sir, because the size of the pneumothorax is very low, very small,
Yeah, yeah.
and it's a spontaneous pneumothorax, so we can admit and observe for any respiratory distress if
Yes, but
there's
how would you define a small pneumothorax?
less than 2 centimeters.
Yes, less than 2 centimeters, which is not growing in size. Because the only way to know that whether it is growing in size, it is increasing, is to observe the patient. Okay, so he just got a pain, he got admitted, and X-ray shows this one. But you never know. In a few hours' time, he might become worse. So always these patients should be admitted and observed. Aspirate with 16G cannula, why is it wrong?
No need any interventions if it's growing in size.
Yeah,
But
it is also right if it is growing in size. So that is not mentioned here. But any moment, if it goes beyond 2 while observing, that information is not included here. So just aspirating a small pneumothorax is not necessary. While observation, if it goes beyond 2, then of course you have to aspirate and see. But if it keeps on filling up again, then you have to insert a chest drain. So insert a chest drain. Also, there is no indication here because no details are given. But those are all right, all correct. Okay, this all can be done, provided the pneumothorax grows in size. Arrange CT thorax is useless because actually diagnosis is very clear here. And it's a young man. We are not going to benefit by finding any other pathology. The usual pathology for spontaneous pneumothorax is congenital cysts. So all are going very close to each other. But remember that what is small pneumothorax, important thing is to absorb, admit and observe. And by any chance, if it is growing more than 2 centimeters, the space, then you can aspirate it and see. But if it is refilling, you must straight away go for a chest drain. Okay. CT thorax is only in older people to diagnose diseases like bronchiectasis or acquired cysts. But in young, healthy male, you are not going to find anything with CT chest. So true will be B. Yes. 55-year-old lady with poorly controlled diabetic mellitus presented with sudden onset, painless loss of vision in the left eye. What is the most likely cause? Any attempts?
E, sir.
E. Why are the others wrong? Why cataract wrong?
It's a chronic condition.
Yes. And
Uh,
generally, yes, vision loss is gradual. So straight away you can exclude that. Increased intraocular pressure, that is glaucoma.
closed angle is very painful.
Yes.
So
So it is generally painful loss of vision, isn't it, in glaucoma? So safely you can exclude that answer. Fractional retinal detachment.
usually associated with trauma.
Yes. And especially occur in whom? It can happen in diabetic mellitus. It's a known complication of diabetic retinopathy, but it doesn't happen immediately or urgently. What happens is that the fractional retinal detachment happens in stages like. So the vision loss is also ultimately at the end, you'll lose the total vision, but it is a more prolonged process. So if it is acute loss of vision, that is also, it can be a true answer. And the D is definitely wrong because refractory errors don't give rise to loss of vision. So that is generally give rise to blurred vision. But the answer will be floating between retinal detachment and vitreous hemorrhage. So out of that, sudden loss comes with the vitreous hemorrhage. Why? It is a well-known complication with diabetic patients. And sudden loss of vision, painless, you have to think of vitreous hemorrhage as the first cause because fractional retinal detachment is a progressive and prolonged disease. So out of these two, E will be the correct answer. Remember all these best of 5 questions, always know the reason why you are excluding the others. So they can be easily converted into true-false answers.
Excuse me, sir. This E, answer E, isn't it
Yeah.
associated with hypertension?
You mean the vitreous hemorrhages? It can
Yes, sir.
happen. It can happen, but diabetic retinopathy also uh, that is a known complication, isn't it? Both can happen, retinal detachment and vitreous hemorrhage. So vitreous hemorrhage is a known complication with diabetic retinopathy as well. If you read around that. So because all these diabetic retinopathy, the vessels are very fragile and the neovascularized vessels, the vessels which form newly, they are very fragile and then acute hemorrhage is a well-known complication. It can happen with hypertensive retinopathy as well, but it is not, but here the main problem is diabetes, no? So it is known to have, known to get in diabetes retinopathy as well, especially with the neovascularization. So hypertension doesn't come, I mean, vitreous hemorrhage is not a special complications or specific complications of diabetic hypertensive retinopathy. So it can happen in both. Okay. 65-year-old male presented with abdominal distension and absolute constipation for 3 days. Closed loop large bowel obstruction was diagnosed, and what is the most appropriate initial radiological investigation that should be performed? Yeah. What is the closed loop obstruction? You have to know. And for 3 days, absolute constipation is called obstipation. Obstipation means constipation for stools and flatus both. So, what should be the SARS initial radiological investigation that should be performed?
E, sir.
You think it's E? Yeah. So how do you exclude the others? Barium meal and follow through? Why is it wrong?
Could be done, sir, to localize the lesion. Yes,
Yeah, that barium meal and follow through is done for what?
Mostly for upper.
Yeah.
The
Barium solos and meals are done to check the upper GI problems. Upper GI obstruction, more than the obstruction, upper GI space occupying lesions, and upper GI, which is up to the duodenum or jejunum. So upper GI investigation is a barium meal, so it is not relevant for this lower GI problem, constipation. So that is out. Then CT abdomen, why is it wrong? Yeah?
not the first line. Initial investigation.
Yes, it says initial radiology investigation. CT will give the definitive diagnosis in most occasions. If it is a tumor or some sort of the cause of the obstruction, you can find by CT abdomen. But that will not be the first thing you will be doing in a casualty ward or in the ward. So first to diagnose the level of obstruction, this is closed loop large bowel. That means there is some sort of a distal obstruction in the large bowel and a functioning ileocecal junction. So what happens is then ileocecal junction is functioning, this obstruction in the distal large bowel, the obstruction get confined to that large bowel area and the high pressure will be imparted on the cecum. So cecal dilatation is one of the main thing you have to look for in a plain X-ray. And you will see the dilated large bowel. Plus, if it is a volvulus or something like that, there are characteristic appearances like coffee bean appearance. So that will help you to find out which part of the large bowel is obstructed to a great extent. So first thing you will be doing is a X-ray abdomen. CT is secondary and MRI generally, emergency settings, we don't do MRI unless CT doesn't give later on a definitive diagnosis. And gastrography in enema for same reason, injecting anything, gastrography enema can give rise to the site of obstruction, but later on, suppose it is intersusception or even a volvulus, gastrography enema can be diagnostic and even therapeutic. But that will all be done after coming to a diagnosis. So first thing you will be doing is X-ray abdomen, supine, which will show distended large bowel, and if it is a volvulus, specific appearance. So because of this reason, it should be E. I think we will finish this session today after this. Yeah. 60-year-old female presents with painless, gradually enlarging thyroid swelling over 6 months. She has no compressive symptoms but complains of mild fatigue, tiredness, muscle weakness, and joint pain. On examination, the thyroid is diffusely enlarged, firm, and non-tender. Thyroid function tests reveal a normal TSH and free T4. Ultrasound shows a heterogeneous hypoechoic thyroid with increased vascularity. What is the most likely diagnosis? Any idea? Yes?
Multinodular bypass.
Okay, elderly female. Okay. elderly female, painless gradual enlargement, no compressive symptoms, fatigue, tiredness, and muscle weakness, joint pain, some constitutional symptoms. Thyroid is diffusely enlarged. Mild nodular goiter, it will be nodular goiter, as name implies. It has to be it should look nodular. It feels nodular. So this is diffuse enlargement.
E, sir?
Yeah.
E?
Okay. Possible, but let us exclude one by one. So, moment you read this type of question, imagine this patient. So he has a smooth enlargement. One is, it's a she, and she has constitutional symptoms. So, and the symptoms are tiredness, muscle weakness, and joint pain. If it says hyperexcitability, increased sweating, and things like that, then it is hyperthyroid. But these features they are features of hypothyroidism to a certain extent, isn't it? So, keep that in mind as you go on. Thyroid function test shows normal TSH and T4. So that is definitely thyroid status is, it's not hyperthyroid. And then, hypothyroid. Ultrasound shows heterogeneous hypoechoic thyroid. If it's multinodular goiter, ultrasound will show that. So if it's a tumor, it will show as a solid nodule. So Graves' disease, one by one exclude. Graves' disease, can it be true?
Hyperthyroidism, sir.
It is hypothyroidism. So there are no signs of hypothyroidism here. And Graves' disease come in younger females. And diffuse enlargement of thyroid with signs of hypothyroidism. And definitely the T4 will be high. And the TSH will be low because TSH get suppressed. Because the hypothyroidism is not due to TSH actually. It is caused by thyroid stimulating immunoglobulin. It stimulates the thyroid, acts like TSH. So T4 should be high. So Graves' disease you can easily exclude. Multinodular goiter for same reason, ultrasound finding and clinical findings doesn't give any clue of multinodularity. So that can be excluded. Hashimoto.
Hypothyroidism, sir.
Hashimoto, actually what happens is initially
Hyper.
it get hyper
And then it
very short period. Then it goes through that whole thing. Then there's a period of becoming hypothyroid because the antibodies, this is the immunological thyroiditis. So the immunological reaction, autoimmune reaction will destroy the thyroid and then ultimately it will become hypothyroid. But in between, there will be a period where thyroid hormones are normal. I mean, today it's hypothyroid and tomorrow it becomes hypothyroid. It doesn't happen that way. So there's an in-between period in Hashimoto with euthyroidism. Initial period, at the beginning it is hypothyroid and that is called Hashimoto thyrotoxicosis or Hashitoxicosis. It's a short period, then becomes a euthyroid period and then thyroid get destroyed and it becomes hypothyroid. So this lady is probably in that in-between transient period. That's why TSH and T4 are more or less normal. But all the other things like, fatigue, tiredness, they are features of Hashimoto's. And also
how long is that period? Normally, euthyroid period?
Few weeks to few months and sometimes years. It takes few months or years to become hypothyroid. That Hashitoxicosis period is very short. It is only the initial period, no particular time period is given, but it's for a short period. And after that, they become normothyroid, but then after few weeks or so, the thyroid cells, thyroid parenchyma get destroyed and they become ultimately hypothyroid. That clues given here is that heterogeneous hypoechoic thyroid. Heterogeneous hypoechoic thyroid means there are no nodularity. So that speaks for Hashimoto thyroiditis. Decavein is out. Why? Decavein or subacute thyroiditis is?
Okay.
Yeah, it's a viral thyroiditis. It is some sort of a acute or subacute viral thyroiditis, and it is painful. And it usually follows a viral illness, unlike in this patient, which is painless. So Decavein is not the best answer. Carcinoma again will come as a nodule mostly, will be picked up in the ultrasound. So putting everything together, Hashimoto will be the best answer. Okay.
So
Right.
what happens to the thyroid status in Duquesne?
Sorry, Decavein.
Yeah,
Decavein, of course, yeah, it's pronounced as Decavein.
yes.
Decavein, thyroid status is nomothyroid. It is a viral thyroid, it's a transient thing. So most occasions it is the thyroid status doesn't become either hyper or hypothyroid. But if the recurrent episodes can happen, but generally the thyroid status is not altered. Better check the literature because I'm not also 100% sure about it. But generally, it is a painful thyroid enlargement, which follows the viral infection.
Okay, sir. Thank you, sir.
Okay, then. So I think we'll call it a day today. And when is the MCQ paper? You all are sitting for this coming exam or what? Forthcoming
Yes, sir.
exam?
18, sir.
On 18th, sir.
Yes. 18th, the surgery paper.
Yes, sir.
Not much
Yes.
time, no? So I'll line up some more MCQs. I mean, whenever you can join, we'll have this class. Okay. Okay, then all the best, and then good night.
Good night, sir. Thank you, sir.
Right, sir.
Okay.
Thank you, sir.
Okay.
Thank you, sir.
You're welcome.
Thank you, sir.